we go to Francesco Sala, who a lot of you know. He will talk about the role of spinal cord monitoring in intraoperative tumor surgery of the spinal cord, or spinal cord tumor surgery, or general surgery. Thank you very much, Francesco.
Thank you, Wilco, for the kind introduction, and also thanks to Professor Zileli. Thank you, Mehmet, for your kind invitation to this webinar. Let me just share my screen. Okay. Can you see the slides?
Yes.
Okay, very good. So what I would like to do in these 20 minutes is share with you some perspective on the value of neuromonitoring in spinal cord surgery, and I will focus on intramedullary spinal cord tumor surgery simply because this is by far the procedure with the highest risk of neurological deficits. This is a recent Japanese studies where they look at the incidence of true positive, therefore cases where there was a monitoring alarm followed by a neurological deficit, plus what they call rescue cases, meaning the cases where there was a neurophysiological alarm, the surgeon took corrective measures, and then there was no deficit. But you see that the incidence of rescue cases plus true positive is by far much higher for intramedullary spinal cord tumors as compared to extramedullary and a variety of other spine surgeries. Now, the history of spinal cord tumor surgery goes back to the beginning of the last century, when Eiselsberg in Vienna was probably the first one to describe the report of a surgery for an intramedullary spinal cord tumor, but certainly Charles Ellsberg in 2095 at the Columbia University described one of the largest early series on this pathology. Interestingly, he was saying that the surgeon should not attempt to remove the tumor in one step because of the high risk of neurological injury. So he was doing the surgery in two steps. The first time was just doing the myelotomy and then waiting for the spinal cord to deliver the tumor in a way. And then he was going back to the surgery a couple of weeks later to remove the tumor, which is an interesting approach. But for many years after Ellsberg, surgery for spinal cord tumors was limited to biopsy and radiotherapy. The risk of morbidity and mortality was considered too high. And it was only in the mid-80s that, thanks to a group of brave neurosurgeons like George Fisher, Fred Epstein, Jacques Brocci, and others, of course, also with the introduction of the MRI and microsurgery, it was possible then to go back and try to remove this tumor from the spinal cord. So in Verona, we found ourselves in an interesting situation because when we introduced neuromonitoring in 2000, we already had a series of about 300 spinal cord tumors operated on without monitoring. And since then, we have operated about 450 tumors now with intraoperative neuromonitoring. As you know, there is a variety of pathologies that can be harbored within the spinal cord. Also in our series, ependymoma are certainly the most common ones, particularly in the adult group. Astrocytomas are prevalent in the pediatric age group. And then third, for incidence, are hemangioblastomas and cavernomas. So our series very much reflect the data from the literature. This is not a perfect scale, but it's still the most used scale when it comes to evaluating neurologically patient with a spinal cord tumor. This is the scale described by Paul McCormick. It's in 4 grades. There is also a modified version in 5 grades, but basically grade 1 is the patient neurologically intact with very subtle neurological deficit. Grade 4 is the patient with a severe upper and lower extremity injury, depending on the level of the tumor, of course, who is not independent and needs bilateral support for walking, or you might need a wheelchair. So generally, grade 1 and 2 are considered good outcome. Grade 3 and 4 are considered rather poor outcome, particularly grade 4 after surgery for spinal cord tumors. Now, this is an old slide, still from Professor Bricolo's series back in the 90s, but I like to show it because it's very informative even nowadays. You see that early after surgery, consider the first week after surgery, probably no more than 10% of these patients come out from the operating room in the same neurological condition they were before the surgery. The vast majority of these patients get worse right after surgery, even if you use neuromonitoring. But fortunately, the vast majority of this morbidity is transient, and most of these patients are able to recover in the long term with the physiotherapy. Now, these are just some of the information about the approach and the technique. So we try to do a plastic laminotomy to decrease the risk of deformity after surgery, particularly in children. Then you try to, most of these tumors are approached posteriorly through the median dorsal raphe. You then look at the dorsal tumor surface identification. You can send a frozen section, which actually is not very useful unless there is a malignancy. But in general, not always the pathologists are able to discriminate between ependymomas and astrocytomas. I consider this surgery a forehand surgery, so I like to have also a rather expert surgeon to assist me, not residents, because this can be quite demanding, particularly if you have astrocytomas and tumor extending for several levels. It's important first to identify the tumor poles and the cysts above and below the tumors, if any. I don't like to use the CUSA unless I need just to debulk a large tumor in order to better visualize the plane between the tumor and the spinal cord. So the key factor is to develop a plane between the tumor and the spinal cord, try to avoid irrigation, to avoid coagulation. We use warm irrigation to maintain the temperature of the surgical field. This is important also for the monitoring. And with the ependymoma, usually the goal is to achieve a total removal because there is a good cleavage plan. With the astrocytoma, it depends, of course, on the histological grade of the tumor. And certainly nowadays, and for 20 years in Verona, intraoperative neuromonitoring has been gold standard during these surgical procedures. So interestingly, before the advent of neuromonitoring, this was a famous statement by John Ranshaw, who was the chief of neurosurgery at NYU. And he was also to say that after spinal cord tumor surgery, if the patient moves, we should have taken more tumor. If the patient doesn't move, then we should have taken less tumor. So this was an interesting post-hoc analysis of the neurological outcome, which nowadays, fortunately, is possible in a more accurate way using neuromonitoring. So in terms of intraoperative neurophysiology, we can monitor a somatosensory evoked potential from the upper and lower extremities, depending on the level of the tumor. Keep in mind that the SCPs assess only the dorsal column pathways, so not the spinothalamic tract, and not at all the motor pathways. One of the problems with the SCP monitoring is that sometimes just opening the median raphe and displacing the dorsal column laterally, you may have a drop in the potentials, which may take some time to recover. So as much as we try to preserve the SCPs, the disappearance of the SCPs is not an absolute criteria to abandon the surgery, because otherwise you will end up abandoning the surgery too early in too many cases. So if we transiently stop, we try to move the dissection to the other side or to the other pole of the tumor. But in general, as long as the MEPs are stable, we proceed with the surgery. I have to admit, though, that the more we are becoming able to avoid and minimize motor deficits, the more patients are coming back complaining for sensory deficit. And we should be aware that lack of proprioception can be as impairing in the quality of life of the patient as a motor deficit. So I think we should give more dignity again to the somatosensory pathways and try to preserve the SCPs as much as we can. Sometimes it may be useful to have a technique to map the dorsal column whenever the classical median raphe with the small vessels entering 90 degrees into the sulcus are not visible. So you can do that. There are at least 3 different techniques, but I will just mention the one which I consider more simple and more straightforward, which was described by Myrella Simon many years ago. So basically, you can stimulate directly the exposed spinal cord. You stimulate the dorsal column from one side to the other side, and you record from scalp electrodes on C3', C4'. So you record like a normal SCPs. So when you cross the midline, on one side, you will have this wave. When you cross the midline, you have an isoelectric flat line. And then you have a mirror image, a phase reversal on the contralateral side. So this is similar to the identification of the central sulcus during brain tumor surgery. So just by directly mapping, you can see where you have your isoelectric line, which corresponds to the midline. You can discriminate the dorsal column on the left and on the right. So this is quite a straightforward and useful technique whenever the midline is not visible or identifiable just based on anatomy. Now, it has been suggested that you can also map the cortical spinal tract. This nice paper by Cohen-Gadol suggests that you can even look at the somatotopy of the different muscles in the spinal cord. But the problem is that, as we show with Vedran Delitis and Kathleen Seidel a few years ago in the Green Journal, is that you can have a motor response if you stimulate the cortical spinal tract, but you can also have a motor response from the muscle if you stimulate the dorsal column. And this is due to an antidromic activation of the somatosensory pathways, which through these interneurons, which will make synapses with the alpha motor neuron. So this is a sort of H reflex. You stimulate the sensory pathways and you will have a motor response. So keep in mind that whenever you stimulate directly the spinal cord, if you get a motor response, this cannot necessarily be due to activation of the cortical spinal tract, but could be the antidromic activation of the dorsal column. There is a technique to discriminate between the two. So you can use two stimuli 60 milliseconds apart. So when you're stimulating the real cortical spinal tract with two stimulation, you will have two response. While if you stimulate the dorsal column, you will have the first response, but not the second one, because the second stimulus follow into the refractory period of these interneurons and therefore will not elicit a response. So this is a little bit a sophisticated technique, but can be very valuable in discriminating if you're really stimulating the motor pathways or the sensory pathways. For the motor evoked potential, then we can either record directly from the spinal cord or from the muscle. If we stimulate with one stimulus and record directly from the spinal cord, we will record the so-called D wave. So you have your epidural electrode placed caudally to the site of the surgery. A D wave stays for direct activation of the axon of the first motor neuron. So you will induce these descending volleys, which synchronously travel along the cortical spinal tract. They can be then detected by your epidural electrode. Now, why is this D wave so important? Because the D wave corresponds to the activity of just a small amount of cortical spinal fibers, no more than 2%. But these are the largest fibers, those with the fastest conduction velocity, the better myelinated fibers, and these fibers have proved to be essential to support locomotion. So as long as we can support and preserve this contingent of fibers, the patient will have good outcome. So we now know for many years that as long as the D wave is preserved, the long-term good motor outcome will be a good one. While if the D wave is lost or it decreases more than 50% at the end of the surgery, that will predict a long-term severe motor deficit. Now, sometimes you have a funny situation where you have a patient who have good motor strength, a good McCormick scale, good muscle MEPs, but you will not be able to record the D wave. And it could happen in the presence of tumor extended for many levels, or patients with long serrings or cysts, or in children who have still an immature cortical spinal tract. So this is most likely due to a phenomenon that we have labeled and called desynchronization of the D wave, which is due to the fact that secondary to the derangements of the cytoarchitecture of the spinal cord, the different fibers conduct with different velocities. So we will not be able to have a synchronous signal which can be detected at the level of the spinal cord, so no D wave, but then you will have a spatial and temporal summation of these inputs at the level of the alpha motor neuron, which will still generate a massive response. So in children, particularly below the age of 2 years, it may be more challenging to record the D wave, although there was a nice publication coming up from Marek Mandera group in Poland recently, where they have a rather good monitoring rate for the D wave, 60%, and a very good predicted value of the D wave for the postoperative motor deficit. Now, the other technique is to record directly from the muscles. In this case, you will need to use a train of stimuli, because this is a polysynaptic pathway. So just using one stimulus, you will not be able to bypass the blocking effect of the anesthetic agents at the level of the alpha motor neuron. By using a trainer stimuli, you will have multiple descending volleys, which travels along the cortical spinal tract, and this will bring to the post-excitatory potential at the level of the alpha motor neuron, which will generate the muscle MEP. We will focus on SCPs and dorsal column mapping during the first stage of the surgery when we approach the tumor, and then as soon as we start to work on the cleavage plane between the tumor and the spinal cord, we will focus on the muscle MEPs and the D-wave monitoring. Sometimes, if the tumor is extended down to the conus level, you can also add the monitoring of the bulbocarbonosus reflex, which provide information about the sacral segments of the spinal cord and the pudendal nerves. And so based on this traffic light color code, we know that as long as the D-wave is stable and the muscle MEPs are stable or they have just minor changes, surgery can continue. We can transiently stop the surgery and move to a different area of the tumor, but in general, there is no need to stop. If the D-wave is still preserved above the 50% of the baseline amplitude, but we lose the muscle MEPs uni or bilaterally, then we stop, we wait. Time is the first corrective measure. Just stop whatever you're doing and wait for the potential to recover. Most of the time they do so. We try to keep the surgical field with the body temperature with warm irrigation, and we try to increase blood pressure if needed, and sometimes we use local instillation of papaveri to try to improve the perfusion of the spinal cord. If the MEPs don't come back, you can either decide to stop or decide to move depending on the oncological goal, knowing that this profile is most likely the one of a patient who will have a motor deficit initially, but will then recover. The point of no return is when the D-wave has dropped more than 50%. At that point, usually the muscle MEPs are already gone. Now I would stop surgery immediately, do all the corrective measures, but if the potential don't come back, the D-wave does not recover, then I would abandon the surgery to minimize the risk to have a permanent motor deficit. A tricky situation is when the D-wave is not monitorable, for example, for a conus cauda tumor because it's too caudal. At that point, you don't know if you lose the MEPs, if this is going to be a transient or a motor deficit. So I would rather stay on the safe side and stop the surgery in the presence of bilateral loss of the muscle MEPs. So these are some data from our series in Verona. We look at about 300 spinal cord tumor cases where we monitor the D-wave. The D-wave was monitored in about 60% of these patients. You see that the monitorability is also related to the McCormick grade, about 80% for patient McCormick grade 1, down to 40% for those in McCormick grade 4. You can see here that early after surgery in the first week, even with monitoring, most of the patients get worse to McCormick grade 3 and 4. But then with the rehabilitation and over time, they all recover. There were only 9 patients out of 160 in McCormick grade 3 and 4. 2 of the 3 in grade 4 after surgery were already paraplegic before surgery. So this is probably the most important slide of my talk, which tells you that if you're able to preserve the D-wave at the end of the case, we are able in 91% of that series, you have about 94% chance that the patient will be able to walk independently at the follow-up. On the other hand, there were only 3 cases where we had to abandon the surgery and leave some tumor behind because of irreversible drop in the amplitude of the D-wave. So this is less than 2% of the cases. This is just one case, T2, T3 astrocytoma, significant drop of the D-wave, disappearance of the muscle MEPs. We decided here to abandon the surgery. The patient got worse to McCormick grade 3, but then progressively he made a full recovery in a few months after surgery. So this is the study we published in 2006, where we showed that with monitoring, we were able to improve the outcome as compared to the historical control group where monitoring was not used. Recently, it has been pointed out that monitoring might decrease the extension rate of tumors. So this is a question mark. In their editorial, David Nazi and Franco Servadei pointed out that maybe this is due to the fact that in many studies, they only monitor the muscle MEPs, but not the D-wave. And the author's reply was that they didn't have now data to support the evidence that D-wave monitoring may reduce the risk of false positive and incomplete tumor resections. So we looked into this recently when we published our series of 100 consecutive ependymomas, all operated with monitoring. We reviewed about 28 articles on spinal cord ependymoma surgery. Out of 20 of them where monitoring was used, only in 3 studies there was D-wave monitoring. The gross total resection rate on average was 83%, about 82% in the series with monitoring, 92% in the series without monitoring, although this was not statistically significant. When we look at our own series, we had a gross total resection rate of 89%, which was very close to the group in the literature where monitoring was used. And the main difference was the use of the D-wave in adjunct to muscle MEP. So monitoring the D-wave in addition to the muscle MEP makes, in my opinion, a difference in the reliability of monitoring and the possibility to achieve a total removal. And so I think there is no evidence nowadays that monitoring prevents a gross total resection, at least in spinal cord ependymomas. And finally, there was an interesting provocative paper coming out from Dublin a few years ago, where they published 70 patients with ependymoma who were operated without neuromonitoring. And the take-home message from the paper was that doing spinal cord tumor surgery without monitoring is safe. You don't have worsening in the neurological outcome more than you have with monitoring, and you can get a total resection rate. So we were very much intrigued by this paper, and we decided to look at our series and then compare the Dublin study with the Verona study. And you can see that the gross total resection rate was slightly bigger in the paper without monitoring. But if you look at the number of patients who got worse to McCormick grade 4, so to paraplegia after surgery as compared to before surgery, this was 12% without monitoring and just 1% with monitoring. So in my opinion, there is no discussion nowadays that neuromonitoring should be gold standard for intramedullary spinal cord tumor surgery. And I will conclude just saying that the ependymomas behave like the Clint Eastwood of the Sergio Leone movie. They are the good ones. Here you can try to achieve a total resection in most of the cases. And you can use monitoring for a stop and go surgical strategy tailored on the basis of the neuromonitoring feedback. The astrocytomas may behave like the bad or the ugly, depending on the histological grade. Here, the goal should be to preserve function, so a safe subtotal removal is a reasonable goal, particularly in children, where with the 80% of resection, you can still guarantee a long-term good outcome in these patients. So I would stop here. Thanks again for inviting me, and I'm happy to take any question.
Thank you, Francesco. Beautiful presentation with all your experiences. And I think you have the right to say that it's more safe to use it. And people who still are not convinced, they are convinced now by your presentation. I already see a question from Hina Pariar. He is talking about the D-wave in kyphosis and scoliotic deformity surgery with the drop of D-wave, but I think that will be for the next speaker, probably. So maybe, Dr. Pariar, we can do that for the next speaker, because he will talk about neuromonitoring of deformity surgery. Francesco, if you think back and you know that from your vision, we also need to train and learn surgery in less developed countries. What's your advice in countries where you don't have the possibility of the material we have in our hospitals?
Yeah, thanks, Wilco. I mean, this is a very important point. Of course, you do what you have, right? I mean, we cannot think that all patients with spinal cord tumors in countries where there is no monitoring will be sent overseas or to a hospital where have all the facilities. So I think it would be important at the global level to try to train some people. We are trying to do that with a couple of colleagues from Africa to at least try to have in some geographical area, a hub center where some neuromonitoring expertise are present, and maybe to centralize some of these high-risk procedures in one place. And as I always say, with monitoring, you do step by step. So if you don't have the expertise or the technology to do motor evoked potential, you can still do somatosensory evoked potential. They are not ideal, of course, but they can still provide some value. If you don't have the D-wave, you can still use muscle MEPs. So the important thing is to be aware of the limitations of the technique you are using. So if you're monitoring only SCPs, you should not tell the surgeon, the SCPs are fine, the patient will move his legs, because of course the SCPs cannot assess motor pathways, but they can provide an indirect information on the well-being of the spinal cord. Now, on spinal cord tumor surgery, you can selectively injure the motor or sensory pathways, which is less the case in spinal deformity surgery. But again, I think that we should try to keep it simple, if possible. Muscle MEPs and somatosensory evoked potential in general monitoring techniques are more complicated than mapping techniques, but for spinal cord tumor surgery, they are definitely more valuable than mapping techniques. I think that the strategy for countries where there is no monitoring is to try to get one center where we can try one person and provide support, and then maybe can centralize some of the challenging cases there.
Yeah, thank you very much, Francesco. So, Mehmet, do you have a question? I see you. Yeah.
Yeah. Wonderful talk. Thank you, Francesco. I want to ask you, what about the cooperation of surgeon, anesthetist, and the monitoring technician or neurophysiologist? If it is not very good, then you may have problems. And another thing is that if the surgeon is not aware of the limitations of the monitoring, he or she can make mistakes and then interpret the monitoring results in a bizarre way. So then relying or no relying, such things happen. What do you think about this?
Yeah, thank you, Mehmet. It's a very important point. So, you already pointed out in your previous question to Elif the problem of having a well-educated neuromonitoring team in the OR. Now, some of these agencies offering the equipment and the experts, we know that in many cases, those experts are not that expert. They have very little training and education. So the quality of the monitoring can be very poor. And this is a risk. I would say that probably it's better to have no monitoring at all rather than having bad monitoring, because you may have misleading information that give the surgeon some self-assurance, which is not really proved by the neurophysiological data. So the first important thing is to have a well-trained neuromonitoring team. And then, of course, the communication between the surgeon and the monitoring team is essential, because the problem is that the monitoring team is analyzing, acquiring, and interpreting the signal. They're providing the information to us, but then it's up to us to take the final decision how to use that information to tailor our surgical strategy, to stop the surgery, not to stop the surgery, to leave tumor behind, not to leave tumor behind. So from this standpoint, I always say that it's extremely important for the monitoring team to know what the surgeon is doing. So they should know the basics of the neurosurgical procedure, also to avoid false alarmism in surgical steps where it's very unlikely that something is happening. But this, again, has to do with the expertise of the monitoring team. But at the very same time, I think it's important for the neurosurgeons to know the basics of neuromonitoring, because otherwise we will just passively receive the information from the neuromonitoring team very acritically without any capacity to interpret that correction properly and integrate that piece of information with all the other information we have. So to give an example, in our residency program in Verona, I have established a mandatory 3 months rotation for all my neurosurgery residents with a neuromonitoring team in the operating room. Of course, in 3 months, you don't become an expert in neuromonitoring, But I want them to at least know the difference between bipolar and monopolar stimulation. What is a D wave? What is a muscle MEP? What does it mean when the D wave drops 50%? What does it mean if you stimulate the facial colliculus or the facial nerve with 1 milliamp or 0.5 milliamp? Or what does it mean to have spontaneous firing on electromyography? These are basic information that is neurosurgeon, I think, should have in order to use monitoring in the best way.
Well, thank you very much, Francesco, for a good answer to Mehmet. And I have the last question for you before we go to the next speaker. And the question is from Yahya Güvenç. She says, very thanks for the nice presentation. He asked, how do you find the corticospinal tracts during the surgery by your electrophysiology? So do you stimulate around the mass when you make the sections or by mapping? Sometimes D-wave decreases when we perform the sections near the tractus. So it's more about the surgical technique.
Yeah, so I usually don't use mapping of the cortical spinal tract during spinal cord tumor surgery, simply because the cortical spinal tract is so tiny and is usually on the periphery, of course, of the tumor, that I don't find mapping very useful. So no, I think that monitoring the MEPs and the D-wave is more important for spinal cord tumors. If you have a tumor which is very large and is already reaching the PIA laterally, I think it's very risky just to rely on mapping, because the cortical spinal tract is so fragile that just trying to get all the way to the PIA, you will injure the cortical spinal tract. So I try always to remove the tumor tangentially to the length of the spinal cord, just to avoid to go from medial to lateral. And I almost never use the CUSA unless I've just already debulked part of the tumor from the spinal cord. So, you can theoretically map the cortical spinal tract, but as I mentioned before, even if you get a muscle contraction, you don't know if you're really mapping the cortical spinal tract or if you are antidromatically stimulating the somatosensory pathway. So in general, no, I find very useful mapping technique for theta record surgery, for example. You can use mapping of the dorsal column to enter the spinal cord in spinal cord tumor surgery, but I don't find mapping of the cortical spinal tract very useful in spinal cord tumor surgery as it is in brain glioma surgery, of course.
Thank you very much, Francesco. So thanks again for a very nice presentation. And now we can go to the next chapter